transfer for upper OBPP. First indication is breeze delivery with eversion of C5 to C6 nerve root, late presentation with good recovery of shoulder function, spontaneous recovery of the upper obstetric brachial plexus palsy without biceps function, and neuroma in continuity of the upper trunk with good intraoperative shoulder muscle nerve condition, the same as a preoperative good shoulder function, but with no bicep flexion. To conclude, this case demonstrate an excellent result of restoration of abduction of the shoulder joint and hand function by muscle release, nerve transfer, and tendon transfer procedure. Thank you for the patience listening.
Thank you, Dr. Rahul. Are there any questions from the audience? Rahul, what did you do for the elbow flexion ultimately?
Sir, ultimately the patient has not reported in the follow-up after the two follow-ups we did for after the tendon transfer, but elbow flexion we are planning to do some muscle transfer in this.
Muscle transfer.
Because the oberlin transfer didn't resulted in the elbow flexion.
So, why do you think the Oberlin transfer did not work in this patient? Can you elaborate upon that? What was the time interval between at what age did you operate on this patient? It was 3 years, right?
3.7 years for the age of the presentation, and we operated in that time only.
So probably that was the reason why the nerve transfer worked, right?
Yes, the lesser age
time was quite long, and the biceps probably did not recover because of the long denervation time. And regarding your choice for tendon transfers, was the pronatas not working?
Yes, sir. Pronata was not working.
The pronata teres was not working.
Yes.
Thank you.
We welcome Dr. Damika and Dr. Ibrahim for chairing this session on stage, sir.
I believe sir has a question.
How much shoulder external rotation you aim to achieve when you are doing this surgery? External rotation.
Yes, sir. Up to 100 degrees, sir.
I mean, 100 is from this to this. 100 is not possible. You can get only up to 70.
Sir, we aimed, but
I'm sorry.
Yes, sir.
It's just asking. Nothing serious about that. But probably shoulder dislocation or subluxation might be there. So you may have to do something for this internal rotation posture also. This is a personal opinion.
Yes, sir.
Okay.
Thank you.
Thank you, Dr. Rahul.
Thank you.
Can I call upon Dr. Abhi Sindhuja for her presentation on experience of posterior approach in brachial plexus injuries?
So one more specific finding that I wanted to mention in this was, in high velocity injuries, there's a chance of the scapular fracture followed by the suprascapular fossa, which is mostly crushed or injured. So in such patients, so this is an intraoperative finding with an avulsed and a scarred suprascapular nerve. So fracture of scapula and avulsion of the SSN is always associated with a difficult dissection of the nerve. Hence, when a nerve is already avulsed or crushing is already present, there is not much of any motor recovery. And hence, in such patients, than attempting this, it is better to go for a muscle transfer. And CT scapula has been done in a couple of patients, and this modality was also very useful to identify the status of the suprascapular notch preoperatively in such patients so that our planning can be improvised. Discussion. Posterior approach has had the advantage of having closer proximity to innervation of the muscle and allows good visualization of the distal course of the suprascapular nerve near the notch. Hence, there's an early recovery that is between 6 to 12 months after surgery. And all studies have also explained that the mean time of recovery is almost 7 months. Studies have also reported a male predominance and association with high velocity injuries and mostly RTA, that is motorcycles. Souza et al.'s study reported an external rotation with the M2, M3 power using the posterior approach, and her results are also similar to our study. Hassan et al. Study on posterior approach also states the mean time of motor recovery was 32 weeks, and it was also correlating with our study and our results. Comparing our study with Jerome et al., the mean motor for shoulder abduction posterior approach was 41 weeks, so which was also correlating with our study. And a couple of studies usually compare the anterior versus the posterior approach, where motor recovery has been the same. But the only advantage of the posterior approach is that early motor recovery was there and direct visualization of the SSN was also present. So the only limitation of the study is the lesser number of patients recruited, and it was insufficient for the statistical analysis. Conclusion. Posterior approach hence offers the direct visualization of both the nerves to be coapted, and therefore it avoids the chance of missing a double crush injury to the suprascapular nerve during exploration, and hence yielding better functional improvement. It also facilitates an earlier recovery compared to the other approach. Thank you for the opportunity.
The dais is open for any questions from the audience.
No, for the outcome of the shoulder, more than MRC grade, you should have only the angle of the angle. Yeah, you should measure with the goniometer kept on the back side. Because if you see the outcome of Naraka's outcome is, if they get a weightlessness feeling, that is a fair result. 15 degrees to 30 degrees is a good result. So unless you have a degree, MRC is no way of identifying shoulder, because you have done only suprascapular. And how will you see MRC grading of suprascapular? It's very difficult. So shoulder outcome should be only with the degree of abduction, and that too with stabilized scapula, because many times they do, with the help of serrators, they may use the scapulothoracic. So that is the main thing. And you said only 2 cases. How many cases you really found injury of the suprascapular?
We have seen on almost 4 patients, sir.
4 out of 74.
67.
67. Yes. And in these 4, did you do a CT? Did the CT had scapular fracture?
So the first patient, when we identify intraoperatively, after that only for all the patients we have done CT scapula, sir. So
do you think it's justified now? Because if you are having a scapular fracture, then it's fine. But in normal non-scapular fracture, are you doing CT?
No,
Yeah.
first we do an X-ray first, sir. So if we are able to rule out if there is no obvious.
So what is your consensus now? If CT is showing involvement of scapula and notch, then will you do it or not do it? What is the?
We can prefer a.
Yeah.
No.
You yourself concluded that it's better not to go for entrance.
Yes.
Dr. Abhi, what was the status of the plexus? Was plexus exploration done in any of these patients? And what was the status of C5, C6 routes? Were they available for nerve grafts?
So this was only posterior approach we had done. We had just identified these nerves. They were not taken for anterior exploration or the plexus exploration.
The plexus was not explored in any of
not
these.
explored in this.
So how many of these patients of 67 were like C5, C6 involvement, where the elbows also paralyzed?
Out of this, 45 patients were pan brachial plexus, sir, and the remaining were upper brachial plexus. Sir. C8T1 was intact in those patients.
Thank you,
sir.
Dr. Abhi.
Thank you, sir.
May I now call upon stage Dr. Omkar Kulkarni for his presentation.
Next. Good morning, one and all. Myself, Dr. Omkar Kulkarni, and the topic for me is Hirayama disease, a rare case of ulnar claw hand. So, a 17-year male resident of Mumbai came with chief complaints of thinning of palm of right hand since 9 months, dryness of hypothenar aspect, tingling sensation of ring finger and little finger since 3 months, and decreased capacity to lift heavy weights with right hands. The symptoms worsened with exposure to cold temperature. There were no other specific complaints like loss of sensation, dysphagia, diplopia, or any past history of any other family disorder or any other comorbidities. No localized pain of upper limb, no signs of compression neuropathy. The right side arm and forearm circumference were decreased by 2 centimeters as compared to the left side. In examination, the positive findings were that the higher function tests were all normal. Right hand showed ulnar clawing and weak wrist flexion. Right hypothenar eminence was atrophied. There were trophic changes of the hypothenar eminence showed dryness. Brachioradialis was spared bilaterally, and deep tendon reflexes were normal. Rest of the proximal and forearm muscles function was normal. In the motor examination, the tone was normal. If you see, the Froment sign was positive. There is weak intraossei action, and tinel sign was negative. There was no localized tinels. Sensory examination was normal in this patient. MRI spine was done in flexion as well as neutral protocol. It showed a focal asymmetric loss of cervical spinal cord at C5, C6 level and at C7 to T1 level, which was more on the right side as compared to the left side. And in the flexion protocol, we found that anterior displacement of posterior dura with prominent posterior epidural soft tissue, which may represent the venous plexus, epidural venous plexus, causing compression of the cord, and it was more prominent of the C5, C6 level. The sensory nerve conduction study were normal. Other blood investigations, vasculitis profile, etc. were normal. F-wave latency was normal. In the motor nerve conduction study, the conduction velocity of the ulnar nerve on the right side was normal, whereas the amplitude was decreased. In the EMG, we found that mostly the C7, C8, and T1 were affected, with ulnar nerve showing on the right side active on chronic partial denervation and ongoing renervation in the EDC. So to summarize, the right side upper limb was more involved than the left side, and right side C8 more than T1 more than C7, active on chronic motor denervation. And site of involvement based on the nerve conduction study was anterior horn cell, along with symptoms of oblique amyotrophy, ulnar clawing, and cold paresis with classical radiological findings. Led to the diagnosis of Hirayama disease by Huashan criteria for definitive diagnosis of Hirayama disease. So coming to Hirayama disease, it's a juvenile insidious onset of unilateral or bilateral asymmetric weakness with amyotrophy of hand and ulnar forearm. Usually it involves the young males with classical cold paresis and coarse temperature, sparing of brachioradialis, and there is a non-specific pattern of nerve involvement. If you discuss with the neurologist will say specific, there is nothing, it does not follow a specific pattern of nerve involvement. There can be atypical findings like pyramidal signs, or sometimes rarely sensory deficit, or even proximal muscle weakness sometimes. So coming to the pathogenesis, what happens, as you can see in this, the posterior dura gets detached, and it starts compressing on the anterior horn cell. If you see here, and that leads to anterior horn cell compression and multiple ischemic insults to the anterior horn cell. And if you see, the target is anterior horn cell itself. Dural sac dysplasia is there because disproportionate length of spinal cord and spinal canal during puberty. Therefore, we see male predominance in this. And spinal ligament asymmetry more on the right side as compared to the left side, leading to the hypothesis that it is more commonly involving the right side as compared to the left side. There is venous dysplasia. That is because of the anterior displacement of posterior dura. What happens is that negative pressure is created in the posterior epidural space, and so the blood flow is diverted into the posterior epidural venous plexus. That again leads to compression in the anterior compartment, and that is classically picked in the MRI. Negative correlation between IgA levels and duration of this disease progression has been studied. IgA deficiency has been contributing to vulnerability of the spinal cord to ischemia in Hirayama disease, but these immunological factors need more detailed study. Khadilkar et al. Suggested that these Hirayama disease patients have relatively longer neck. MRI findings, the conventional MRI will show atrophied lower cervical cord and a
We apologize for the technical inconvenience. It will just take 2-3 minutes of your time. Kindly cooperate.